Hello, my name is Sandra. I'm a nurse practitioner student at William Patterson University. I will be performing an assessment, a physical exam of your head, eyes, ear, nose, throat, heart, and lungs today. Do you consent to that? We're
Yes.
going to be filming. Can you tell me your name,
Enrique
last name,
Roman,
and your birthday?
December 5th, 1967.
Thank you. I just finished washing my hands, so now I'm gonna go and start with your head and face inspection. So just looking around, I don't notice any lumps, any masses, any, the skull is symmetrical. I don't see any depressions. His shape is normal, okay, and it's a normal cephalic. And for the face, I don't see any facial droop, which indicates that there's no Bell's palsy, there's no strokes. And then in the skin, I don't notice any skin abnormalities, some papules on the cheeks, but I don't see any other abnormalities in the skin of the face. His contour is symmetrical, his nose is midline, his eyes are bilaterally equal, and his eyebrows are evenly distributed with the hair. And I think with that, we're gonna conclude the head and face examination. I'm gonna ask the patient to please smile, frown, puff your cheeks, and squeeze your eyes shut. With that, we just tested cranial nerve 5 and 7, which are intact in this patient. Next, I'm gonna be palpating the temporal and masseter joints. Open and close your mouth. Good. Okay, I don't hear any clickings. And that tells me that the temporal masseter joint is intact. This patient is normal cephalic for the inspection of the head. So I will be checking your sensation. That's cranial nerve 5, which is trigeminal. Just let me know if you feel me touching equally on both sides. You feel the same?
Yes.
And what about the top?
Yes.
Bottom?
Yes.
So this patient, cranial nerve 5, trigeminal is intact. Next, I'm gonna be moving to the eye exam. So first, I'm looking just at the eyes. The eyes are bilaterally equal on the same plane of the face. Eyebrows are evenly distributed. I don't see any discharges. I don't see any styes. I don't see any lumps or masses in his face. I'm gonna check the lacrimal apparatus, and I don't see any discharges. I don't see any redness. His sclera is white. His cornea and his iris appear round, equal, both sides, same color. All right, I'm gonna look at the conjunctiva, which is nice and pink and moist. I'm gonna look down. Okay, same here. Clear is all white, his sclera. Okay, very good, excellent. So now I'm gonna have you read these letters. I need you to please cover one eye. And if you can read the the smallest line.
L, T, F, P, H.
Very good, and then cover the other eye.
L, T, F, P, H.
And then now you're gonna read it from up close.
L, T, F, P, H.
Very good. So that is just tested near and distant vision, which is intact in this patient. I'm gonna be now moving to the peripheral vision. So with that, I'm gonna need you to close one eye, and I'm gonna close the opposite eye. And what I need you to do is that I need you to tell me how many fingers you see.
1, 2.
Without moving your eye.
1, 2, 1, 2, 1, 2.
The other eye now.
1, 2, 1, 2.
Okay, so with that, we conclude the peripheral vision, which is intact in this patient. Now I'm going to be doing the corneal light reflex. I'm going to shine the light directly into the bridge of your nose. The light reflection should be symmetrical in both pupils. So I'm going to come over here. Okay, the light reflection, it is both sides equally and bilaterally. And any imbalance with the light would indicate strabismus. Also, I'm gonna now do the pupillary reaction, comparing each side. Pupillary reaction is good. His eye dilated, his pupil dilated and constricted bilaterally, and that's testing accommodation. Any unilateral constriction or dilation could indicate some type of brain lesion or drug use or herniation. Okay. Next, I'm going to be moving to the extraocular movements, with that I'm going to be testing cranial nerves 3, oculomotor 4, cochlear, and 6 abducens. And I'm going to be doing the 6 cardinal fields of gaze. Okay. So you're going to be following this pen light, but without moving your head. Okay. So I'm going to start here. The extraocular movement is assessing convergence. Eye movements that are not parallel could indicate muscle weakness, and is looking. I was looking for any nystagmus, any abnormal movements of the eyes, and in this patient, cranial nerves 3, 4, and 6 are intact. Next, I'm going to be moving into the fundoscopic examination. Okay, starting my fundoscopic exam, I'm going to look into the patient's eye, and I'm gonna be visualizing the optic disc and the fundus. So I'm gonna go right eye, looking for the right reflex. Okay, I could see the right reflex, so I'm gonna now move in. And I could see the vascular. I don't see any swelling, any edema. I don't see any bleeding in there. It appears pink, round, and the sharp edges, the optic disc. Okay, checking on the other eye, I'm going to go move in, looking for the red reflex. I'm going to move in closer. Look straight ahead. I can see no redness. The optic disc has clear margins. There is no edema. Vessels are there. I can visualize them. I don't see any bleeding, and no other abnormalities there. Next, I'm moving onto the ears. I'm inspecting the outer ear, the auricle, the tragus, and they are proportionate to head size, straight in line with outer contours of the eye. Okay. I'm gonna palpate now. I don't see no discharges. I don't see any drainage. I don't see any blood, so that's good. Any drainage, any blood could indicate trauma, or it could even indicate acute otitis media. I'm now gonna palpate the auricle. Any pain when I touch your ear?
No. No.
And on the tragus, any pain?
No.
All right. And mastoid process. Okay, so no pain?
No.
Gonna now use my otoscope to inspect the auditory canal and the tympanic membrane by pulling the pinna up and back. As I'm moving in closer to the ear, I'm looking to see if there is any serum, drainage, and I'm looking inside the ear. Okay, the tympanic membrane appears pearly gray and translucent, the way it's supposed to be on this ear. I see the cone of light at 5 o'clock on this ear, and I don't see any bleeding, any pus, any drainage in there. It appears intact. And now I'm going to move into the other ear. Again, moving the pinna back and out, up and out. Going in, and again on this side, I'm looking for drainage, and a clear drainage could be indicate a basilar skull fracture, but this patient's eardrum and tympanic membrane is pearly gray and translucent without drainage, blood, and the cone of light on this ear is at 7 o'clock. I don't know any bulging of the tympanic membrane on this side, which can indicate acute otitis media. I don't know any bulging of the tympanic membrane on this side, which can indicate tympanic acute otitis media. I'm now going to be doing the whisper test. So I'm going to ask my patient to cover one ear, and I'm going to say a word, and I need you to repeat the word that I say, okay?
Water.
Good, excellent. And then you're going to cover the other ear, and I'm going to say
Food.
okay, excellent. So that tells me that this patient's cranial nerve 8, vestibulocochlear, is intact. He can hear, but I'm still gonna demonstrate how to do a Weber test and a Rhine test. Okay, next I'll be performing a Weber test. This is going to test for bone conduction. So striking the tuning fork, I'm gonna ask my patient if you feel the sensation and the sound bilaterally, if you hear it.
Yes.
Equally?
Yes.
Equal on both sides? Very good.
Okay.
Excellent. Thank you. Any localization on the intensity of tone of either side is abnormal, and it means conducting hearing loss. Next, I'm moving on to the Rhine test to compare air conduction to bone conduction. So I'm going to be placing the tuning fork behind your ear, and I'm going to ask you to tell me when you stop feeling it first, and then in the front when you stop hearing it, okay? Tell me when you stop feeling it.
Now. That's it.
Tell me when you stop hearing it.
Now. That's it.
So with this, one more time.
Now. That's it. Now. That's it.
Air conduction should be greater than bone conduction. A negative Rhine test indicates conductive hearing loss in the affected ear. Next, I'm moving on to the inspection of the nose. I'm looking to the nose. I see the nose is midline. I don't notice any lumps, any masses in his nose. It is proportionate, and I'm gonna now palpate. Do you feel any pain or tenderness?
No.
Okay, have you been congested recently?
No.
Okay, so there is no pain or any tenderness. I'm gonna ask you to please cover one nostril and take a breath from the other one, in and out. Okay, do the same on the other side. Very good. So that indicates that his nares are patent. Okay, so I will be checking the patient's frontal and maxillary sinuses. Any pain, any tenderness there when I touch your frontal sinuses?
No.
Okay, and then the maxillary?
No.
No tenderness?
No.
Okay, very good. Excellent. Next, with my pen light, I'm gonna look into the internal nasal cavity. I'm gonna ask you to look up for me. Looking in the mucosal, mucosal inside is nice pink and moist. There's no drainage. There is no masses. His mucosal is pink. Same on the other side. I don't see any deviation. Any deviation can indicate sleep apnea. Okay. As I said before, any deviation of the nasal septum could indicate sleep apnea or obstruction. And any grayish color in the nasal cavity and the nasal mucosa could indicate allergies. So now I'm going to be doing the checking the olfactory, which is the cranial nerve 1. I'm going to ask this patient to smell something, and he can describe what he's smelling. Okay.
Lavender.
Very good. Excellent. So with that, we just tested cranial nerve 1, which is the olfactory. Okay, and now inspecting the lips. Lips are smooth, intact. There's no cracking, no lesions, no swellings. His lips are pink and they're moist. Any dryness of the lips can indicate dehydration. Any paler of the lips can indicate anemia. Any bluish color on the lips can indicate cyanosis. But I don't see that in this patient. His lips are nice and pink and moist. So next, I'm going to ask my patient to open his mouth and look up for me. I'm looking inside the hard palate, soft palate. I'm looking on the sides for color. Color of the buccal mucosa is pink, it's moist. His teeth are all evenly on both top and bottom. If they are white, there is no signs of decay. There's no missing teeth. I don't see any lesions, any signs of thrush. Could be like a cottage cheese. Okay, and next I'm gonna be putting some gloves to inspect the buccal mucosa. The parotid gland opening is inside the cheek across from the molar and it's visible. The salivary glands are visible. Next, I'm going to be inspecting the tonsils. I'm going to ask my patient to open his mouth and say ah. The uvula rises and falls, which shows me that his cranial nerve 10, the vagus nerve, is intact. I'm looking now at the tonsils. Tonsils are bilaterally equal, pink, no drainage, no exudates, no swelling there. Any pain in your throat?
No.
Okay, swallow for me. Any pain when you swallow?
No.
With the patient swallowing, I can visualize the cricoid cartilage, which rises and falls symmetrically, which shows me that the cranial nerve 9, which is the glossopharyngeal nerve, is intact. If you can please open your mouth and take out your tongue and move it from side to side and open down. Open down, okay. All right, great. So that is testing cranial nerve 12 hypoglossal, and his cranial nerve 12 is intact. So next I'm gonna be palpating his tongue, take out de la boca, just moving it from one side to the next, noting any lesions, all right, and I don't. His tongue is pink and moist. Any smoothness of the tongue could indicate vitamin B12 deficiency, but in this case, open. Your tongue is nice and smooth and moist without any lesions. So now I'm gonna be assessing cranial nerve 7 and 9, which is the facial and the glossopharyngeal for taste. I'm gonna ask you to tell me if it's sweet or salty.
Sweet.
And that's correct. That was honey. So this patient's cranial nerves 7 and 9 are intact. Now I'm gonna be assessing my patient's lymph nodes. So I'm gonna, lymph nodes should be non-palpable and movable. So I'm going to be starting with the preauricular lymph nodes. Post-auricular lymph nodes. Submandibular lymph nodes. Again, I don't feel anything, so that's a good sign because it should be non-palpable. Submental lymph nodes. Superficial cervical. Posterior cervical. Occipital lymph nodes. And subclavicular lymph nodes. And again, these patients' lymph nodes are non-palpable. Any palpable lymph nodes, especially in the supravicular area, could indicate some type of infection or malignancy. Did you feel pain when I palpated your lymph nodes?
No.
Okay, so these patients' lymph nodes are non-tender and non-palpable. Now checking the range of motion of the neck. So if you can pull your head back and then chin to chest down and then side to the other side, and his patient's range of motion is active range of motion of the neck. Assessing the carotid pulses, so I'm gonna go one side for one at a time. It's there, I palpate it. Okay, it's good. I don't hear no abnormalities or no bruits. Checking the trachea position, should be slightly deviated to the right, and it is, but if it's too deviated, it could indicate pleural effusion or pneumothorax. Next, I'm checking this patient's thyroid gland. So I'm gonna do posterior and anterior. I'm gonna ask the patient to swallow. Okay, I'm gonna ask the patient to swallow, and I'm gonna listen with the bell. Any whooshing sound in the auscultation of the thyroid can indicate hyperthyroidism. In this patient, I don't hear anything abnormal. And his thyroid is midline without any lumps or any masses or anything palpable there. Okay, and now assessing the thyroid posteriorly. Can you swallow again? And I don't feel any masses or any lumps on the thyroid on both sides. Okay, now with the respiratory assessment, checking now the posterior part of the chest. So with that, I'm inspecting the skin, and I'm also going to be doing thoracic configuration. Do you have any pain anywhere?
No.
I don't feel any depressions, any bulgings, and there's no tenderness. And I'm moving on to thoracic configuration, so please take a deep breath. Okay, so his thoracic one more time. Thoracic configuration is symmetric. Checking for tactile fremitus, I'm going to ask the patient to repeat the word 99, and I'm going to go from the top to the mid-back. So can you please repeat the word 99?
99, 99, 99, 99.
So with this, the tactile fremitus is present. Any decreased tactile fremitus could indicate emphysema or pneumothorax. Next, I'm going to be checking the diaphragmatic excursion of the patient. So since we are on the back, we're going to stay in the back, and I'm going to percuss from the top until I go from resonance to dullness. All right. I'm not going to measure, but I'm going to and it's about here where I go from resonance to dullness. I'm going to do the other side. Okay, it's here. So I want to say that for the diaphragmatic excursion, the normal fineness is no more than 3 to 5 centimeters, and that is the case in this patient. I'm going to ask you to turn around to auscultate your lungs. I'm going into the anterior chest. First, I'm going to be listening with the bell. Take a deep breath. So with the anterior chest, I don't hear any adventitious breath sounds. I don't hear any wheezing, any crackles, any rhonchi. His lung sounds are clear in the anterior chest. I'm gonna listen again in the posterior chest. And also with that, I check the thoracic configuration in the front, which is symmetrical. Again, I'm going to start with auscultating the lungs from the back. Take a deep breath. Especially tone sounds are clear bilaterally. This patient respiratory rate is 14 and non-labor. I don't hear any adventitious breath sounds, no crackles, no wheezing, no rhonchi. So that concludes the respiratory assessment. Now starting the cardiovascular assessment. So I will be auscultating the different heart sounds. With that, I'm gonna start locating. So I see the sternal notch, and from there, I'm gonna go down to the angle of Lewis, and now I'm gonna start auscultating, locating the aortic sound, which would be the second intercostal space to the right sternal border. And I hear it there, the heart sound. And that's S2. And now moving to the left side on the second intercostal space, left sternal border is where my pulmonary sound is, which I hear a lobed up. From there, I'm going to go down to the third intercostal space, lateral to the sternal border, and that's where the Erb's point is. And that's my tricuspid right below that. And I hear the lobed up. Now I'm going to go down to the fifth intercostal space and going down to the midclavicular line. I'm auscultating there, and that's where my mitral valve is and where the S1 is heard the best. Represents the beginning of systole. I don't hear any gallops, any extra sounds. There's a regular rate and rhythm. I don't hear any murmurs. Very good. Now I have my patient at a 45-degree angle to assess for jugular vein distension, and I don't notice any jugular vein distension in this patient. Any jugular vein distension can indicate heart failure. So now I'm going to move down to the aorta, the abdomen. I'm going to palpate the aorta, which bifurcates above the navel. Checking for any masses, and if I put a little pressure, I'm not going to put too much pressure, I can feel the palpation, the pulsation. Then I'm going to listen to that aorta. I don't hear any bruit. Then I'm moving to the renal arteries bilaterally, which is about mid-navel on both sides. Then the iliac arteries bilaterally, no bruit noted. And now the femoral. Gonna lower this a bit. Okay, it's present without bruit. Excellent. So now I'm going to be moving on to the popliteal artery. So I'm going to expose the patient's legs. I'm looking for circulation in the legs. Hair is evenly distributed. There is no lesions, no masses, no ulcerations. Okay, I'm going to go right behind the knee here for the popliteal artery. Relax your legs. And it's deep palpation here, but I do feel it. And I don't feel anything abnormal there, so it's present without any bruit. I'm checking the posterior tibial artery. And again, no bruit. 2+. Then the dorsalis pedis, 2+ in this side, 2+ in this side, no bruit present. Checking the capillary refill, less than 3 seconds bilaterally. Now I'm going to move up to the upper extremities, where I'm going to be checking now for the radial and brachial pulse, radial and ulnar, and then brachial. So first, starting with the radial pulse, I'm checking there. Strong bounding, 2+. Ulnar now. Strong bounding, 2+ again. Okay, and I'm going to do the Allen test, where I'm going to occlude both arteries, the ulnar and the radial, and we're going to open your hand, close your hand, close again, open, close, and I'm going to let go. That's it. Leave it open. And I see that the blood flows goes back to the hand. Then I'm going to do it again, and this time I'm going to check for the ulnar. So I'm going to occlude both, open and close. We see the pelvis, and then when I let go of the ulnar, we see the color goes back there. So that is good. There's no occlusion there. I'm going to do the other side also. Checking for the radial pulse on this left side, which is 2+ bounding and is strong. Checking now for the ulnar pulse on this side, which is again strong and bounding, 2+. Now I'm going to perform the Allen test on this hand, which I'm occluding. Open and close your hand. Letting go, let go. And when I let go of the ulnar, the color of the hand goes back to red. And then I'm going to now check for the radial. Open and close. Checking for the Allen test in this hand. So I'm going to ask my patient, open and close your hand. I'm occluding both. Okay, and then I'm letting go of the radial, and the color goes back. So that's good, that's intact. Let me give him a second here. Now I'm going to do it again, and this time I'm going to check for the ulnar, open and close. Okay, see the pill, and then when I let go of the ulnar, I see the color going back to all red in the hand. So that indicates that there's no obstruction of any of the two arteries. And now I'm going to check the brachial pulse on this side. Okay, brachial pulse is strong, is bounding, and is 2+. No, let go, let go, let go. Bounding, strong, 2+, bilaterally. Next, I'm gonna be checking his pulse and the radial and the brachial. So this patient pulse is 82 beats per minute. So now I'm checking for capillary refill in the upper extremity. So with that, checking. Again, capillary refill is less than 3 seconds bilaterally in the upper extremities. And with this, we conclude our cardiovascular assessment.